When I talk about expansion, many people use the term RME. Now, RME is not the name of an appliance, it's actually the rate you turn an appliance. The correct term is Hyrax. So you can have a banded Hyrax with bands on the 6s and rests on the Ds, like we showed yesterday, or you can have a bonded Hyrax, which is an acrylic appliance. So if I can show you the bonded Hyrax appliance, this is an older design and one that is no longer in use but was originally described in the literature. I think the best reference for the bonded Hyrax is the reference by Jim McNamara that's published in JCO, where he's used this appliance in conjunction with a reverse pull face mask in a deciduous dentition and also showing the design outline in an adult dentition. So looking at this appliance, you can see that it's the older screw. So this is called a jack screw. The reason I don't use the jack screw anymore, A, I found it very difficult for patients and their parents to engage that little hole. B, I found a lot of tipping with this, and C, a lot of relapse when the screws would sometimes turn back. As you know, we have now changed to the super screw, which I've talked about yesterday. I'd recommend that everyone obtains a copy of this brochure. This is written by the developer of the super screw, Dr. Lewis Clapper, and it's probably the best summary on maxillary expansion, the objectives and what appliances are used. Now the super screw comes in two sizes. It comes in a 16 and a 12 millimeter. We only use the 12 millimeter because we never need to get more expansion than that, and that is with the green key, whereas the other bigger super screw comes with a gold key. Now, in this brochure, not only does Dr. Clapper discuss the benefits of the super screw, but it shows clearly why we don't get the tipping that we see with the other expanders and why we get better stability. This is the wrench that's used to activate the super screw, and this is the gauge we discussed yesterday so that the parent can actually measure and I can monitor how much expansion we are achieving. As far as indications for a bonded Hyrax versus a banded Hyrax, I use a bonded Hyrax in any vertical case. So if I have a child with a long face and I want to minimize the extrusion of molars, the bonded Hyrax with slower expansion is the way to go. I also use it in any class 3 mid-face deficient case where I need to apply a face mask. That could be a brachyfacial, a neutral, or a high angle patient. Why? Because as I want maxillary protraction, I need the posterior disclusion and I need maxilla almost to slide over mandible. So bonded Hyrax indications are narrow palate high angle case or any mid-face deficient class 3 patient you're employing a face mask. One article I'd like to draw your attention to, which was published in Angle Orthodontist, and this is in 1997. It was a combination article, and the main author is Stephen Ansana, and it talks about the comparison between Hyrax, which is the standard expander, and the bonded Hyrax. And it measures the differences and comes to some interesting conclusions, particularly regarding vertical dimension. So that's another research-based article, but I would like people to be more familiar with the super screw. Now let's go through the old design. Older screw, no tube to engage the wire, so very hard to combine this with a 2x4 setup. On top of that, when you went to remove this appliance, you had this metal wire where you would place your band remover and you would then lift the appliance. In another clinical video, we'll show you how to remove a bonded Hyrax. I think that's the more difficult part rather than fitting it, particularly if there's deciduous teeth present, because the deciduous teeth will tend to exfoliate with the removal of the expander. The old expander had this metal bar so that you could put the band removing plier like so, press and as pressing, it would fracture along this line, so you could take it out in 2 parts. We've redesigned the bonded Hyrax now with a couple of features. The main feature is that the entire framework of the expander is embedded throughout the appliance, which makes it easier to remove, and the removal can be done in one piece rather than waiting for the fracture. What else can we see about this design? There's the super screw in place. I've added a 022 molar tube so that I can combine my anterior 2x4. Positioning of this tube is very important. If I don't have a face mask, in this case, and the patient that we're going to fit this for, it's a class 3 mid-face deficient patient where I will be using a face mask. But if I don't need the face mask hook, I'd like my 022 tube to be as mesial as possible to limit the emergencies between 4 anterior brackets and a long spanning wire. I see a lot of labs put the 022 tube where you conventionally would with a banded Hyrax, but that doesn't work in this situation. So don't allow your lab to put this molar tube right at the distal. Put it as far mesial as you can, unless you've got a face mask hook. So in this design, you can see the less bulk of the acrylic. The acrylic should only cover a half of the tooth. If it covers all the way down to the gingiva, it becomes a plaque nightmare, and we get a lot of gingival irritation. When we fit this appliance, we sandblast the tissue fitting surface to improve retention. There's holes within the acrylic for the adhesive to escape so that it doesn't sit high. We use the same cement that we are using for the banded Hyrax, which is the 3M multiband cement, but with a slightly runnier mix. And the concept is to ensure that on the mesial and distal of that molar tube, you block out so that GIC cannot get stuck in there. If it gets stuck in there, you'll never be able to do your wire in the 2x4 technique. So, sandblast. We don't need to etch the enamel for the teeth, but if you sandblast here and have a good mechanical retention, what's the chemical retention of the band cement, you're ending up with more than enough retention. If you sandblast the teeth or micro-etch the teeth, we end up with the problem where the appliance is too retentive and very difficult to remove. So again, a couple of design features: framework of the super screw embedded throughout the acrylic so it can be removed in one piece. Position of the 022 tube. The amount of acrylic not to cover the entire surface of the tooth, but only halfway between the gingiva and the occlusal surface. In this design, because it's going to be used with a face mask, we have the reverse pull hooks, and again they are embedded all the way through to the framework. This appliance should have been sandblasted in the lab, but we will sandblast before fitting, again to improve retention. And the sluice holes, or the holes that allow the GIC to escape, it will be fitted in the mouth. Before the light cure occurs, a wet cotton roll is then wiped all around the surface. This is the most important surface to clean, because if any extra GIC gets stuck there, it irritates the gingiva and we start getting swelling. Once all the excess GIC has been removed, the patient actually bites hard on the appliance and we finish light curing. After light curing, we do an occlusal adjustment with articulating paper to make sure the patient's hitting evenly. If they're only hitting on one side, that's a great way to unseat the appliance. So occlusal adjustment before the child leaves is important. What I suggest is fit it, trial fit it, do an occlusal adjustment outside the mouth, then bond it in position and do the final occlusal adjustment inside the mouth. If you fit this and then try to do your occlusal adjustment and realize that you need 4 millimeters of acrylic removed on one side, it's very uncomfortable to do that inside the patient's mouth. So the technique we're now going to show you in the patient's case is fitting, trial fit, occlusal adjustment, then micro etching, blocking out the openings of the tubes and anywhere where glue may get into the Hyrax, then using the runnier version of the multi-band cement, fitting, removing excess, light curing, and then doing the final occlusal adjustment. This is a bonded Hyrax with reverse pull face mask hooks for a face mask which will fit at a subsequent appointment. I'd like to introduce young Matthew. Thanks for coming along today, Matthew. How old are you?
10.
10. So Matthew has a class 3 mid-face deficiency, and our objective in treatment is really to get the maxilla wider and forward. Can you show them your teeth, Matthew? Bite together. Right. So do you know why you're here today?
I have an underbite, but I want a overbite.
Do you want to ask me any questions?
No.
No, nothing's going to hurt. It's very, very simple. After we fitted it, I'm going to show Dad how to turn that little key. All right? Great. We're going to trial fit now the bonded Hyrax in the mouth and then use articulating paper to see if it's hitting evenly. I also look at the degree of opening. Sometimes the technician puts too much acrylic and the patient leaves with a massive open bite, which is going to make it difficult to chew and also encourage an anterior tongue thrust. We just want minimal acrylic, so many times, even though it's hitting evenly, I will take some acrylic off and we'll show you that process.
Okay. All right, together.
Tap, tap, tap. Bite as hard as you can. Yeah, good boy. And then tap, tap, tap. Bite as hard as you can.
Open. As you go down. That's it. Yep. And bite together. Open. Bite together again. It's pretty even. Hitting there, and there.
Yeah. So you can see here why I'm not going to take any more acrylic off, because as Matthew's biting, he's just clearing his crossbite. If I take more acrylic off, then it'd be harder for us to kick those upper incisors over the bite. So good vertical, good even contact, well-made appliance. I congratulate ProTech for that. We send all our appliances all the way to Canada, even though it costs a fortune because the quality is fantastic.
This aids in our bonding micromechanical retention. The adhesive will stick a little better to the acrylic. You can see the difference, the chalky, sandy appearance, cloudy appearance there, which we've just sandblasted, and this side we haven't. So it means the bond particles can enter in between those little tiny cracks and bond to the material. I'll sandblast the other side and we'll fit it.
So another thing I want to point out, just for clinical significance in Matthew's case, this is the new sort of format prints that we can do from our CBCT machine, and it's amazing technology. It allows me to relocate where things are. So here's the upper arch. You can see we have a very small lateral, possibly a peg, and we have no room for the cuspids, and we can see exactly where the cuspids are coming through. We can then invert that view on the inside. We can have a look at the palatine suture. I can rotate this view any way I like. We normally do this on the computer, but I printed this out specifically for today's session, and I use this a lot in my letters when I write back to the referring dentist and doctor. You get a really nice view of the maxilla. So no room for the lateral, certainly no room for the canine, and the whole concept is possibly a smallish tooth present and coming down into position. And so the concept of treatment here is going to be to widen the maxilla, bring it forward to correct the class 3, make room for the canines to fall into position. One thing I also want to add, if you want to improve retention on these appliances, is to improve the chemical interface between the glass ionomer cement and the acrylic. Sandblasting is certainly one method. Another way of increasing bond strength is to use technical acetone. So not the acetone you'd use to sort of clean, remove nail polish, etc. This is made by an industrial chemist, And what this does, that softens the acrylic and allows better adaptation of the glue to the acrylic. So another tip, if you don't want to sandblast, is to use this. Alternatively, if one does debond and you've sandblasted it, when you put it back the second time, I would definitely recommend this to soften any residual glue that might be on there after you've sandblasted and improve your mechanical retention. So we're showing here the doctor putting the acetone on the expander, getting it ready, and at the same time he's doing that, the nurse is mixing the multiband cement, which we've talked about in previous lectures. So the amount you normally need to cement a bonded Hyrax is 5 scoops of powder and 5 drops of the liquid. How can you measure the 5? On one side of the scoop is a flat 3, the other one's a single. So 2 singles, 1 large scoop. That's 5 scoops of powder with 5 drops of liquid. And the most important thing is, because this sets like rock, you make sure that none of this flows into the super screw or into the opening of the 022 tube. So in preparation, we've sandblasted, we've acetoned, we've checked the occlusion, we've blocked out with chapstick or Vaseline the opening to the tubes. Now we're starting the mixing process. Each of these procedures needs to be followed in detail so that we have less chance of bond failure, particularly when we apply the face mask, which is 600 grams of force in a downward forward pull direction.
I bet you put your chin up a bit higher. Perfect. I can see everything. That's beautiful.
Good boy, keep biting hard as you can, that's it.
That's it.
So we're just showing here how you wipe away the excess cement before it sets. And remember, this will actually set even in the presence of light. One of the problems we're having with filming all these procedures is the light from the over the head camera is quite strong. It's an LED light, so we've got to work quite quickly. So now, after removing the bulk with the cotton roll, we're going back in and taking, while the glue is still soft, any of the residual flow. What you've got to understand here is when the patient bites hard, a lot of this will escape gingivally, and if it sets hard subgingivally, that's the biggest plaque trap. So now we've checked the fit, got rid of the extra cement. Now we're light curing both the doctor and nurse simultaneously using the Demitron lights. Okay. Remember, with this cement, you don't need to fully cure every part of it. This starts the polymerization process, so it actually will cure underneath the acrylic where the light may not be able to shine, same as when we cement banded appliances. This is a resin modified glass ionomer cement, so we have much better strength than a conventional GIC. As I said, I've tried many things on the market. I always come back to 3M multi-band cement for cementing Hyraxes, whether they're bonded Hyrax or banded Hyrax. And you'll see once this is set how that glue becomes clear. And one thing you have to warn parents, particularly with the stops on the premolars for the banded Hyrax, is that if a little bit of glue comes off, the parent assumes the tooth's broken, because what comes off and the patient brings in their hand is tooth-coloured glue. So I always warn patients and their parents that if they think the tooth's broken, it's not, it's just the glue that's been coming away. So little tip here, when we're checking the occlusion, if you put Vaseline on the articulating paper, there's less chance of it tearing, and you actually get a much better demarcation or marks on the teeth. So tap together, tap, 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 hard as you can.
And open. This side, tap, open. Tap, tap, tap. And open.
Nice and big, good boy.
Bite together.
Bite together. Good, that's it, fine. Yep, excellent. Yeah, So in an ideal world, that's exactly what would happen. But of course here you haven't got the cheek in the way and things like that. So that's just a demo key. Your actual key I'm going to give to you now, and I'm going to get you just to do one turn in the mouth for him, and then I'll turn it back. So the process is we're fitting the expander today, and then probably 4 or 5 weeks when he's more comfortable with the expander, we'll add the face mask. And the face mask is to help correct his class 3 jaw, bring the upper jaw forward.
Off the front.
Now, it's just if I can just, can you open really wide for Dad? So the best way to turn this is on his bed. You know, if you try and do it while he's standing up, it's pretty hard. So can you see on the right side, you won't see any lines now, but that's where the gauge will appear. Now, what I don't want is to go past at any stage for him 4 lines.
4 lines, right?
Because we need about 10 millimetres of expansion. 4 lines is 8.
Okay.
And some parents, you know, they do it so well, they think that if we turn it a bit more, we'll get there quicker. Right.
Yeah,
so the max it can ever expand is going to be 5 lines, but for us it's going to be 4. Right. So this is
the 12mm one, isn't it?
Correct. Yeah. This is your actual key, right? So can I get you at every visit to bring that in as well?
Okay.
Just can I get you to open really wide?
Wide, chin up, nice and high, like we did. Perfect.
All right, mate. See.
Open bigger, open bigger.
Open wide, big guy. Push your tongue down. Just.
It's not engaging just there, that's it.
No.
So spin it around, that's it, perfect. That's nothing to do.
There we are. It's on there, Matt. I just turn it.
So good. Open really wide for Dad now.
Open wide. I turn it down.
Yep.
And I turn it back up.
That's it.
Don't unwind it. You've just unwound it then.
Yeah.
So that turn it down and then straight out.
Now already, can you bite together, mate? Thank you. Already, can you see that the upper teeth have cleared the lower?
Yeah,
so that's going to help things straight away. See, before that went in, he was biting like this.
Well, that's exactly right.
I've designed that so that when he bites now, he can't push his lower jaw forward anymore. So that, with the face mask, is going to get us from an underbite to an overbite.
Hey, how cool is that, buddy?
All right?
Excellent.
Good.